Friends, I am Dr. Ashish. Welcome to my channel Live Biochemistry. Today we will discuss about the phenylalanine and tyrosine metabolism. Okay. So phenylalanine and tyrosine, they are the aromatic amino acids. Phenylalanine is an essential amino acid. It is not produced in our body, so has to be supplied in a diet. So it is a essential amino acid, while tyrosine amino acid can be produced in our body from phenylalanine. So now what are the disorders associated with the phenylalanine and tyrosine metabolism? So one is very important, is phenylketonuria. Okay. Then tyrosinemia and alketonuria. Okay. So now we will see the metabolism of phenylketonuria, phenylalanine and tyrosine. So what is the first step? First step is phenylalanine is converted to tyrosine. Enzyme is phenylalanine hydroxylase. And here with the help of oxygen, so what is tyrosine? It is nothing but phenylalanine plus one hydroxyl group is added, and it requires a coenzyme called tetrahydrobiopterin. So it will be converted to dihydrobiopterin. Okay, tetrahydrobiopterin is converted to dihydrobiopterin and phenylalanine is converted to tyrosine. This dihydrobiopterin is converted to tetrahydrobiopterin again by the enzyme called dihydrobiopterin reductase, and it requires the NADPH. So NADPH will be converted to NADP. And if this phenylalanine hydroxylase enzyme is deficient, it will lead to the classical phenylketonuria or type 1 phenylketonuria. Okay. Symptoms and diagnosis of phenylketonuria we will see later on. And if this dihydrobiopterin reductase enzyme is deficient, it will lead to the non-classical phenylketonuria or type 2 or type 3 phenylketonuria. Or by any way, if this biopterin is not synthesized properly, it will lead to the type 4 and type 5 phenylketonuria. Okay. Now what will happen to this tyrosine? Phenylalanine converted to tyrosine, then tyrosine is converted to PHPP, para-hydroxyphenylpyruvate. An enzyme is called tyrosine transaminase. And here it requires the vitamin B6 and alpha ketoglutarate is converted to glutamate. Okay. And if this enzyme is deficient, tyrosine transaminase, it will lead to the type 2 tyrosinemia. It is also called as the Richter-Hanhart syndrome, where there is a oculocutaneous manifestation occur, hyperkeratosis will occur. Okay. Then this PHPP is converted to homogentic acid or homogentisate by the enzyme called para-hydroxyphenylpyruvate hydroxylase or dioxygenase. It requires vitamin C, okay, and copper. And if this enzyme is deficient, it will lead to type 3 tyrosinemia, which is also called as the neonatal tyrosinemia. Now this homogentisate is converted to malonyl acetoacetate. An enzyme is called homogentisate oxidase. And if this enzyme is deficient, it will lead to alketonuria. Okay. Now this malonyl acetoacetate is converted to fumarate acetoacetate by the isomerase enzyme, and it requires a tripeptide called glutathione. Okay, and here for homogeneous oxidase it requires the iron. Now this fumarate acetoacetate is converted to fumarate and acetoacetate by the enzyme called fumarate acetoacetate hydroxylase. And if this enzyme is deficient, it will lead to the type 1 tyrosinemia. We have seen that type 2 tyrosinemia where tyrosine transaminase enzyme is deficient, type 3 tyrosinemia where there is a PHPP hydroxylase enzyme is deficient. In type 1, which is the most fatal, where there is a hepatorenal syndrome occur, hepatic and renal failure occur, cabbage odor urine is there, okay, and children die within 2 years. So this is very important, type 1 tyrosinemia where fumarate acetoacetate hydroxylase enzyme is deficient, okay. And this fumarate will go to the, can be converted to malate, oxaloacetate, and ultimately the precursor of gluconeogenesis. So it is called glucogenic. While acetoacetate is a ketone body, that's why this phenylalanine and tyrosine both are called glucogenic and ketogenic amino acid. Now again I revise. So phenylalanine converted to tyrosine by the phenylalanine hydroxylase enzyme. If this enzyme is deficient, it will lead to the classical phenylketonuria. If dihydrobiopterin reductase enzyme is deficient, it will lead to the atypical or non-classical phenylketonuria, which is type 2 and type 3. And if this biopterin synthesis defective, it will lead to type 4 and type 5 phenylketonuria. Now this tyrosine is converted to PHPP, para-hydroxyphenyl pyruvate, by the transamination reaction. If this enzyme is deficient, tyrosine transaminase, it will lead to tyrosinemia type 2. Then PHPP converted to homogentisate by the PHPP hydroxylase, which require vitamin C and copper. And if this enzyme is deficient, it will lead to type 3 or neonatal tyrosinemia. This homogentic acid converted to malate acetoacetate. Okay, again it requires vitamin C and iron, and if this homogentic oxidase is deficient, it will lead to the alketonuria. Accumulation of homogentic acid will be converted to the benzoquinone acetate and it polymerizes to the alkeptone body, which is a black color pigment. This malate acetoacetate is converted to fumarate acetoacetate with the help of glutathione and isomerase enzyme, and this fumarate acetoacetate converted to fumarate plus acetoacetate. Enzyme is fumarate acetoacetate hydroxylase, and if this enzyme is deficient, it will lead to type 1 tyrosine. Okay. So now we will discuss about the phenylketonuria. So why this phenylketonuria occur? Because the classical, there is a enzyme deficiency is phenylalanine hydroxylase. If this enzyme is genetically is absent, then accumulation of phenylalanine. This phenylalanine will be converted to phenyl pyruvate by the transamination reaction. This phenyl pyruvate can be oxidatively decarboxylate to phenyl acetate, and it can be reduced to phenyl lactate. This phenyl acetate again react with the glutamate to form phenyl acetyl glutamine, okay, which can be excreted in urine. And the mousy odor of the phenylketonuria, mousy odor of the urine is because of the phenyl acetate. So in case of phenylketonuria, phenyl pyruvate, phenyl lactate, phenyl acetate, phenyl acetyl glutamine, all substance will be accumulated in blood and in the urine. Okay. And in phenylalanine hydroxylase is deficient, this is called classical phenylketonuria. If dihydrobiopterin reductase enzyme is deficient, it will lead to the type 2 and type 3 phenylketonuria. If biopterin is deficient, it will lead to type 4 and type 5 phenylketonuria. Now what are the clinical manifestations? So in this patient, there will be mental retardation, development delay, intellectual disability, IQ low, usually less than 50 IQ is there. Patient has a hypopigmentation of skin, hair because of the decreased melanin. Why there is a decreased melanin in phenylketonuria? Because tyrosine will not be formed because phenylalanine is converted to tyrosine. Okay, if this enzyme is deficient, then tyrosine is not formed, and tyrosine is a precursor of melanin. We will see that with the help of tyrosinase enzyme, tyrosine is converted to melanin. If tyrosine is not formed, then melanin is not formed, and in absence of melanin, is the light color skin and hair occur. Okay, so these are the symptoms of phenylketonuria. Now, how we will diagnose? First, increased level of phenylalanine, phenylactate, mousy odor. Which are the mousy odor urine? Which are the laboratory investigation? Guthrie test. Guthrie test depend on there is a Bacillus subtilis bacteria. They require phenylalanine for the growth. So more the phenylalanine level, more the growth occur. Okay. Then another lab is phenyl ferric chloride test, FeCl3. It will be purple green color if phenylalanine is increased. But nowadays it is diagnosis is mainly by the tandem mass spectrometry. Okay. And we have to, one very important point here is we have to diagnose, if you want to diagnose this phenylalanine at birth, in this patient, phenylalanine may be normal. Why? Because during fetus life, increased phenylalanine level, they will be transported via placenta. Okay, so there will be normal phenylalanine level, but after 1 to 2 days after starting feeding, the phenylalanine level will be high. So always when we want to take the blood, dry spot, we take after 48 hours. Okay, that will suggestive of increased phenylalanine level. So this is a very important point. Now diagnosis. After diagnosis, come to the treatment. We have to give the diet which is low in phenylalanine. If we continue giving the phenylalanine rich diet, then the IQ will be lower, okay, and there will be mental retardation. So it is very important point to early diagnose the patient. Okay, and we can give vegetable fruits which is less in phenylalanine. Alright, and we have to avoid artificial sweetener, that is called aspartame, which is a dipeptide which has a phenylalanine. Okay, so artificial sweetener contain aspartame, contain the phenylalanine. So we have to avoid this. Okay, this is very important. And if the mother, pregnant woman, has a phenylketonuria, then the child will have a microcephaly and congenital heart disorder. So this is all about the phenylketonuria. Incidence is 1 of 20,000 newborn, but now the incidence is increased because of the better diagnostic facility. Why it is called phenylketonuria? Because phenyl pyruvate is accumulated, which is a keto acid. Okay, and there is a mental retardation is a very important feature. And as we have seen, phenylalanine level is increased because of the phenylalanine hydroxylase enzyme deficient. It will be converted to phenyl pyruvate, phenyl acetate, phenyl lactate, with phenyl acetyl glutamine. Okay. So mental retardation, hypopigmentation, all are the features of phenylketonuria. In type 1 classical phenylketonuria, there is a phenylalanine hydroxylase enzyme is deficient. But non-classical or atypical phenylketonuria, type 2 and type 3, there is a dihydrobiopterin reductase enzyme is deficient. And in type 4 and 5, there is a dihydrobiopterin synthesis is defective. Now we will see the case of phenylketonuria. So here you can see that a 1-year-old child with a delayed milestone and history of mousy odor from the diaper. So what is the most probable diagnosis? So here the diagnosis is phenylketonuria. What is the biochemical cause of mousy odor? Because there is a phenylalanine hydroxylase enzyme is deficient, phenylalanine is accumulated. Accumulated phenylalanine is converted to phenylpyruvate. Phenylpyruvate is decarboxylated to phenylacetate, and phenylacetate is the cause of mousy odor. Okay, what are the inborn error of aromatic amino acid metabolism? So it are phenylketonuria, tyrosinemia type 1, 2, 3, and alkaptonuria, and albinism also. Draw the reaction catalyzed by the deficient enzyme. I will draw in few minutes. And what are the essential amino acids that are not produced by our body? So it has to be synthesized in the diet. What is the test for diagnosis of this condition? So tandem mass spectrometry nowadays, but earlier Guthrie test and ferric chloride test. Okay. So I draw that reaction, that is phenylalanine, again phenylalanine converted to tyrosine, okay, and phenylalanine hydroxylase enzyme, and oxygen is converted to H2O, and it requires a coenzyme called biopterin, the tridobioterin. It is converted to dihydrobiopterin, again converted back to tetrahydrobiopterin with the help of dihydrobiopterin reductase. Dihydrobiopterin reductase, and it requires the NADP. Okay. So now we will see one more case of phenylketonuria. Here, a 5-year-old who has complained of mental retardation, seizure, delayed milestone, light color hair, skin, phenylalanine level is more than 30, normal 1 to 2 milligram, Guthrie bacterial inhibition, assay and ferric chloride test, so blue-green color. What is the diagnosis? Phenylketonuria. What is the possible cause for the disorder? Phenylalanine hydroxylase enzyme deficient. Why patient exhibit light color hair? Because of the tyrosine is not formed, and tyrosine is a precursor of melanin. In absence of melanin, there will be light color hair and skin and eye. Which metabolites appear in the urine? So phenylpyruvate, phenylactate, phenylacetate, these are the substances that are accumulated. So just your line of treatment, we can give the patient the diet which is low in phenylalanine. Okay. This is about the case. Now, as we know that different type of tyrosinemia. So as we have seen that metabolism, phenylalanine is converted to tyrosine. Tyrosine is converted to PHPP. PHPP converted to homogetisate. Homogetisate converted to melyl acetoacetate. Melyl acetate converted to fumaryl acetoacetate. It is converted to acetoacetate and fumarate. So if here enzyme is tyrosine transaminase, if this enzyme is deficient, it will lead to the type 2 tyrosinemia, where there is a, it is also called the oculocutaneous tyrosinemia. There is a hyperkeratosis of the palm and plantar region, and it is also called as the Richner-Hanhart syndrome. Okay, this is all about tyrosinemia type 2. If this PHPP dioxygenase enzyme or PHPP hydroxylase enzyme is deficient, it will lead to type 3 tyrosinemia. It is also called as the neonatal tyrosinemia. Okay, and one more version of PHPP dioxygenase, if it is in heterozygous form, then accumulate product of tyrosine metabolism it binds with the cysteine and it will form one product which is called Hopkinsine, and Hopkinsine-urea will occur if there is a heterozygous deficiency of PHPP dioxygenase, and it will lead to the swimming pool odor. Okay. And if fumarate acetoacetate hydrolase, that will convert fumarate acetoacetate to fumarate and acetoacetate, it will lead to type 1 tyrosinemia. It is also called as the hepatorenal syndrome. It is very fatal. Okay, and there is a cabbage odor. This is all about the different tyrosinemia. Okay, so if fumarate acetoacetate hydrolase enzyme is deficient, it will lead to the type 1. There is a hepatorenal failure, so hepatic and liver and kidneys fail, rickets occur, polyneuropathy occurs. Child die within 1 year. That is type 1. In type 2, it is Richter-Reinhardt syndrome. There is a tyrosine transaminase enzyme deficiency. In neonatal, that is called type 3 tyrosinemia. There is a PHPP dioxygenase or hydroxylase enzyme is deficient. It turns to normal. Okay, and we have to give diet low in phenylalanine and tyrosine. Now, what is alkaptonuria? When this homogetisate, which is converted to normally mallyl acetoacetate enzyme is homogetisate oxidase. If this homogetisate oxidase enzyme is deficient, it will lead to the accumulation of homogetisate. This homogetisate on oxygen, it reacts with the it will form benzoquinone acetate, which will polymerize to alkapton body. So accumulation of alkapton body in the connective tissue, that is called as the pochromosis. Okay. So homogetisate oxidase is deficient, it will lead to the black color urine. Okay. So dark black color urine is typical of alkaptonuria. And this deposition of this alkapton body lead to ochrosis. Ochrosis will cause the tissue damage, arthritis and backache. Okay, not life-threatening, but condition is not treated. Now, one drug is there, which is nitisinone. What this will do? It will do inhibition of PHPP dioxygenase. So, homogetisate oxidase, homogetic acid is not produced because PHPP is converted to homogetisate, which therefore this PHPP dioxygenase. If this enzyme is inhibited, that homogetisate is not produced, so it will be helpful in that patient. Okay. So I see another one more case. A 4-year-old child has a black color urine. Okay. Growth developments are normal. So which substance can be accumulated? So here black color urine because of the homogetisate. Okay, and enzyme deficiency is homogetic oxidase. So this is your answer B. But methylmalonate, this will be accumulated in vitamin B12 deficiency. Phenylpyruvate in phenylketonuria. This is in the B12 deficiency, and alpha keto isovalerate in the maple syrup urine disease. Okay. So as you can see here, there is a mentally retarded child suggestive of phenylketonuria. Black color urine, which is suggestive of alkaptonuria. Again, black color pigment in the hand, in the nose, in the pinna, all are suggestive of alkaptonuria. And in recent NEET PG exam, it is asked alkaptonuria, 2 questions were asked. Okay. And what is your disease diagnosis? There is a hyperkeratosis of the palm and plantar region. So keratitis is there. So what is this? It is a type 2 tyrosinemia. Okay. Which enzyme is deficient? Tyrosine transaminase. Which enzyme is deficient in neonatal tyrosinemia? PHPP hydroxylase. Which enzyme is deficient in type 1 tyrosinemia? That is fumarate acetoacetate hydroxylase. And what is this? Hepatorenal failure, that is a type 1. Fumarate acetoacetate hydrolase enzyme is deficient. Okay. What is this? Black color pigment in the pinna and sclera. It first deposited in the sclera. Okay. And it is alketonuria. Which enzyme is deficient? Homogentisate oxidase. Okay. This is all about the today's lecture. Now we will see what are different two MCQ. Tyrosinase, most common cause is this tyrosinase is type 1, hereditary tyrosinemia, type 1. So fumarate acetoacetate. So this is your answer. Fumarate acetoacetate hydrolase enzyme is deficient. Tyrosine transaminase with enzyme deficiency lead to type 2 tyrosinemia. EHPP hydroxylase enzyme deficiency lead to type 3 tyrosinemia. Homogentisate oxidase lead to alketonuria. Okay. Type 1 tyrosinemia is due to the fumarate acetoacetate hydrolase enzyme deficiency. Okay. Tyrosine transaminase with type tyrosinemia type 2. PHPP hydroxylase type 3 or neonatal. Metyl acetoacetate isomerase. Okay, it requires the glutathione as a tripeptide. So this is all about the tyrosinemia. Okay, thank you very much for listening my video. Please like, share and subscribe to my channel. Okay, thank you very much.